Hi there. In the last lecture, we talked about a conceptual model of how one might improve the effectiveness of the treatment system that has developed to manage alcohol and/or drug problems. And in particular, we suggested that the model would predict that the more integrated the services are and the more services that exist, as well as equity and efficiency and the lack of stigma and a lot of other things, that we could improve the population impact of treatment. Now I'd like to talk about whether there has been any research that would suggest that the greater the number of services and the better the coordination of services, we're getting better population impact. And the fact is that there hasn't been a lot of research on this. So I hope this would intrigue you to think about how you could try to answer this important question using the epidemiological research skills that you'll learn in this course. Most treatment research is designed to investigate efficacy and effectiveness. Efficacy is under optimal conditions where you can control the therapist and the types of patients who get a treatment and the type of treatment that's delivered and how long it's delivered. If you can get good outcomes, that's important because it suggests that treatment is resulting in a causal way in better outcomes. Effectiveness is when you do it under real-life circumstances. And even an efficacious treatment may not be effective in the real world because of all the other things that interfere. So, and that means that even at a population level, we may have good treatments out there, but they're not adding up to a reduction in the population rate. So, we know from research that addiction treatment can improve psychiatric functioning, medical and employment outcomes, and it can also reduce or even eliminate the amount of alcohol and drug use that a patient has. So abstinence treatments result in maybe a third of the patients actually stopping drinking or drug use, another third reduced, and another third find it difficult. Treatment can also affect the social environment where families are concerned and communities. So treatment can have ramifications far beyond the patient. On a population level, how would we measure this? Well, we can measure it in terms of taking a cohort of people who are heavy drinkers or drug users and following them over time and looking at death rates in terms of premature mortality compared to people who don't use alcohol and drugs at a very high rate. So when you follow up people in treatment, you can look at their mortality rates, and what you find, as you might expect, is that alcoholics and drug addicts have 5 years or more taken off their life expectancy if they continue to use those substances. You can also measure population impact by the number of people coming into hospitals for mental disorders, alcohol and drug-related conditions, accidents rates, homelessness, criminality. There are all kinds of indicators that might reflect whether or not a treatment system is leading to improvements in population health. And in fact, there has been some research. Some of the early studies were done by people at the University of Toronto, the Addiction Research Foundation. And what they looked at was across provinces in Canada and across states in the United States, was there a correlation between the number of people coming into Alcoholics Anonymous, where you'd expect they're being helped to achieve recovery by abstinence, and liver cirrhosis, morbidity, and mortality. And lo and behold, what they found was the more Alcoholics Anonymous groups there are, the lower the cirrhosis rates. The more people coming into regular treatment, the lower the cirrhosis rates. And we also looked at, or they also looked at, accidents and injuries from traffic accidents, and they were correlated with attendance at AA meetings in a negative way. So the more treatment services we have, the lower the rates of alcohol-related problems. That's correlational, but it's very important information, and it's quite exciting. Drug treatment changes have been made at a systems level as well. And in some countries, there have been dramatic changes in the availability, for example, of opiate substitution services, or what we call medication-assisted treatment now, in countries like France and Switzerland, where all of a sudden they put lots of money in setting up methadone maintenance and buprenorphine treatment centers. And when that happens, crime rates go down, more people get into treatment, and overdose rates go down. This has also happened in countries like Iran and China, where massive amounts of money have been put into opioid substitution treatment, in part because of epidemics of HIV infection and overdose deaths. And we've seen similar favorable results. More treatment, better organized treatment, lower fatality rates. Creation of a drug court system in the United States and now in other countries seems to be a way of coordinating services so that people, when they're convicted of a drug-related crime, are given a choice. They can go to prison or they can go to treatment. And for most people, it's an easy choice, and treatment is effective for them. They're monitored and they're brought back into society. So a drug court system has the probability of influencing thousands or tens of thousands of people to seek abstinence by motivating them in a positive direction. And there are lots of other things we can do to improve the treatment systems, including clinical practice guidelines that show clinicians how to use the tools that are effective. We've learned similarly in other countries about the impact of the availability of different types of treatment. In psychiatric disorders, the use of antidepressants has been effective in at least correlating with reduced suicide rates, and that is an important finding because it suggests that introducing treatment might have a positive population impact. Nevertheless, we don't see clear examples in many countries of the connection between the treatment service system itself and the population rates of alcohol and drug problems. And that raises the question, why does the burden of substance use disorder persist despite adding more and more services? In some cases, we can see reversal of epidemics. In other cases, we don't see anything. And it may be that we're just not measuring it properly. It could be that the figures are wrong. It could be that the treatments are ineffective. But we just, I think, have implied in our review of the treatment literature through clinical trials that at an individual level, treatment is effective for many people, and that should add up to a population impact. It could be that eligible patients are not receiving treatment, so not enough people are getting into the treatment system for it to have a population impact, or it could be that patients are not receiving effective treatment. Remember what we said about the difference between efficacy and effectiveness. You can demonstrate in a clinical trial that a treatment is efficacious, but it may not work in the real world because a lot of factors interfere. Or maybe we have effective treatments, but they're just not being used by clinicians. So we need to persist in trying to demonstrate how this system model might improve population health. It's important. It's important because in the area of drugs, for example, the high-level segment of the Commission on Narcotic Drugs concluded that after 10 or 15 years of international collaboration to try to drive down the rates of drug abuse and drug-related crime and HIV infection. In 2009, they concluded that it isn't working. And they said, we got to do something better. Most of the money for drug control goes into supply control, interdiction, crop eradication, a lot of things that cost a lot of money. And what the Commission on Narcotic Drugs concluded was that we've got to pay more attention to treatment services. We've got to coordinate between supply control and demand reduction. We've got to have effective primary prevention, early identification, treatment, and rehabilitation based on the scientific evidence. That's good news for epidemiologists like us because it means that in many countries, particularly the United States, they're going to be looking for answers. They're going to be looking for research. They're going to be looking for data that tells us how we can improve the treatment system. But this balanced approach that's comprehensive and it looks at integrated services is something more and more that we're going to be seeing. And as epidemiologists, we need to be able to study treatment systems in order to provide answers for policymakers.